STC Hematology Conference. Our goal today is to discuss high-risk chronic lymphocytic leukemia. We are pleased that it is being sponsored by AstraZeneca and also endorsed by ESH, OSH, Saudi Society for Blood Disorders, and CME is available also through Saudi Commission for Health Specialties. Today, we are very pleased that we are joined by four very eminent faculty. We have Dr. Ayman Al-Hijazi, Dr. Wojciech, Dr. Iman Al-Hazmi, and our colleague, Dr. Amar Lal. Our first talk will be with Dr. Ayman Al-Hijazi, who will be telling us what exactly does high-risk CLL patient means and how do we manage these patients. This will be followed by Dr. Wojciech, and he will be talking to us about, for these high-risk CLL patients, should we consider continuous therapy or is there a place for time-limited therapy? Subsequently, Dr. Iman will be talking about translating clinical data into practice, followed by some clinical case scenarios by Dr. Lal. So I would like to invite our first speaker, Dr. Ayman Al-Hijazi. He's an assistant professor of hematology oncology, as well as a head and consultant division of adult hematology and stem cell transplantation in King Abdulaziz Medical City. Please welcome Dr. Ayman Al-Hijazi, and he will be talking to us, as I mentioned, what exactly high-risk CLL patient means and how do we manage them. Thank you.
Well, thank you very much. I guess I can't see the, can you hear me? Can you hear me?
Yes, Dr.
Very well.
Yeah, okay, because I lost the control of the video and audio. Anyhow, good evening, everybody. Thank you, Dr. Arif, for the nice presentation and introduction. And I would like also to thank AstraZeneca for inviting me to speak in this tonight with this nice faculty. So my role is to discuss the definition of high-risk features of chronic lymphocytic leukemia. So we know for a fact that chronic lymphocytic leukemia is a disease that does not have a defining genetic lesion similar to CML. We know in CML that BCR-ABL translocation defines the disease, and targeting this only abnormality will change the outcome of the disease. Unfortunately, CLL is not such a disease, and it also does not have a high background mutation load. There is, as I mentioned, no unifying gene mutation. There are multiple mutations that can happen, such as TP53 mutation, Notch1, SF3B1, ATM, and they are usually, upon presentation, not really commonly seen in new patients. This is back in the old days where certain cytogenetic abnormalities before employing the or using the novel agents where certain cytogenetic abnormalities, and we still holds true most of the time, but as we go in the talk, we will see that this may really change based on the outcome of new trials. So we had typically we had the 6q, 11q, 13q deletions, trisomy 12 and 17p deletion. We know that 17p deletion carries the most worst prognosis with median overall survival of less than 3 years, followed by 11q deletion, which has a survival of 5 to 6 years. And then the three categories where we have trisomy 12, normal cytogenetics are 13q deletions. Patients are expected to have an median overall survival of 10 years or more. And this is what we have seen over the years by treating CLL. The TP53 aberrations and immunoglobulin heavy chain variable region mutational status are the main markers of high-risk features within CLL. But let's go into more details probably. As you can see in this study, they have also looked at both TP53 mutation and 17p deletion, whether there is one or both. As you can see, if you have only TP53 mutation without deletion, because I'll explain it in the subsequent slide, or deletion, this is the wild type. If only mutation or deletion, more or less the same, but the worst prognosis happens when you have both. One allele is mutated and the other is deleted. As you can see here, this explains it in a better way. As we know, we have two 17 chromosomes. If one is mutated and the other is deleted, this carries the worst prognosis, which is represented here. But here, for example, this is only 17p deletion in one chromosome, and the other chromosome carries the wild type of TP53. This is a mutated TP53, but the other chromosome is normal. So as I said, having both chromosomes affected, one with mutation and the other with deletion, carries the worst prognosis. This pie graph shows you the distribution of the TP53 aberrations that can happen within CLL. Deletion and mutation happens in about 40%, about 35% have 17p deletion, no mutation, and about 23% have only mutation without deletion. The overall survival of these patients, we know, is very much affected by the presence of these mutations or deletions. This pyramid or triangle shows the factors that may decide on which protocol or treatment approach do we follow for each patient. And with the development of these novel therapies and many protocols that we can use, we are approaching what we have been trying to reach as a goal, which is personalized medicine. The most important, as it lies in the base of this triangle, is disease biology. And this what dictates which treatment you need to give to which patient that has a certain cytogenetic abnormality or certain disease factors that will respond to a certain protocol. Of course, not less important is the patient preference on what protocol to use, drug profile, safety, and patient profile, of course, the presence of comorbidities and others. All of these dictate which protocol you use, the easiest to give and the most effective in each patient. Again, TP53 gene mutation or deletion, in addition to immunoglobulin genes, are the backbone of biological risk stratification in chronic lymphocytic leukemia. Now, patients with aberrant TP53 gene, we know, and as we have seen, respond poorly to chemoimmunotherapy. But how much is significant of the TP53 aberration or mutation? We can see here in this pie graph, which was published a long time ago, stratifying patients on how many of them get TP53 aberrations by different methods or techniques of identifying these aberrations. So around 70% or even more, honestly, have wild type. But if you do it by FISH, you get 14%, and by next generation sequencing, you can add 16%. But This is probably more than what we usually see now. It's about 5 to 10% probably, which have P53 aberrations before starting first-line treatment. This is the European Research Consortium recommendations on how much is really significant of TP53. So the recommended threshold by NGS sequencing is 10% of VAF. VAF is the variant allele frequency, and it's defined by the number of variant reads divided by the number of total reads and expressed in a percentage. So 10% was chosen arbitrarily as a threshold, above which it's positive, below which is negative, but it's not really a magic number. But still, labs should probably report 5 to 10% of VAF variant allele frequency. That can also impact the outcome of these patients who have a low allele frequency of TP53 mutation. This is from the Alliance trial, which just to, as I mentioned, now with these more new agents showing probably efficacy and overcome some of these cytogenetic abnormalities that we have mentioned earlier, that we knew that it carried a poor prognosis. So the Alliance trial randomized ibrutinib or ibrutinib plus rituximab versus bendamustine rituximab. This to the left-hand side is the curve showing patients, and this is the subgroup analysis of these patients, not the whole trial. Results. As you can see, the Kaplan-Meier curves here. So in 17p deleted, as you can see here, very good outcome as compared to BR. 11q, the same. And when you have neither or, chemotherapy or BR does way better than when you have 17p deletion or 11q. Deletion, proving the fact that, or the notion that chemoimmunotherapy is not really a choice, especially in patients with 17p deletion, if you have a better agent that can overcome these cytogenetic abnormality negative effect. This is from the Elevate treatment naive, using, again, comparing acalabrutinib obinutuzumab or acalabrutinib to chlorambucil obinutuzumab in the subgroup analysis where they had 17p deletion or P53 mutation. As you can see here, again, the acala or acala obinutuzumab have similar outcome. A 4-year median PFS, 4-year PFS of 76%, compared only to 18% on the obinutuzumab chlorambucil. And the median PFS was not reached in these two top curves, which was 17.5 months for obinutuzumab and chlorambucil. And this probably will be talked about in further details by the subsequent speakers. Acala versus rituximab Idela, again showing that acalabrutinib has a better PFS. Median was not reached, but median for Idela or bendamustine was 20 months or 13.8 months, respectively. We come to the venetoclax, which is another novel agent, BCL2 inhibitor. And this is from the CLL14 trial, where venetoclax was combined with obinutuzumab versus chlorambucil obinutuzumab. And this is, again, the different groups with either B53 mutated or not. As you can see here, the top two curves are the venetoclax or obinutuzumab, but the top curve where you have wild type and no TP53 mutation, and the lower curve, the solid blue line, represents patients with TP53 mutation. The two red lines are for chlorambucil obinutuzumab. As you can see here, I mean, the two top curves are not really overlapping. There is probably, when you use a BCL2 inhibitor as compared to BTK inhibitor, the presence or absence of TP53 mutation makes a difference in outcome if you use a BCL2 inhibitor. We talked about immunoglobulin, the TP53 gene, which is the most important as that carries the worst prognosis in patients with CLL. Now we come to the immunoglobulin heavy chain variable region mutational status, which is known to be a marker of prognosis. Now, upon presentation, probably 30% of patients are mutated. 60-70% of patients have unmutated immunoglobulin heavy chain variable region. But let's look at the mutated group. Are all immunoglobulin heavy chain variable region mutated CLL? Are they equivalent? Do they behave the same? Let's look at these genes beyond the somatic hypermutation. There is what is called a PCR stereotypy that happens in about 41% of patients. What is this? So the discovery of almost identical, or what we call here stereotype BCL receptor immunoglobulins among unrelated CLL patients suggested that certain antigen selection may play a role in the disease pathogenesis. Approximately 41% of these patients can be grouped into different subsets based on shared sequence motifs within the immunoglobulin heavy chain variable region. And that region is called the IGHV region, complementary determining region number 3. And it seems that some of these subgroups, stereotype subgroups share similar prognosis. For example, stereotype subset number 2, which is called IGHV3-21, may be associated with an unfavorable prognosis independent of the mutational status of the immunoglobulin heavy chain variable region. But as of today, the assessment of these stereotypes is not part of a routine testing or a routine prognostic workup, but this was studied by Halleck and the group and was published as blood guidelines. So stereotype subsets are clinically relevant in the subset number 2. You can see these curves here, and subset number 2 of those who were thought to be mutated, carrying good prognosis, represented by the green line here, is really having a poorer prognosis than the usual other IGVH gene mutated group. This is to prove the concept that not all immunoglobulin heavy chain mutated patients have a better prognosis, but a certain subset, about 10 to 15% of them, which we call subset number 2, also have a poorer prognosis. similar to the unmutated. These are the original slides, the original curves of CLL8 by Fisher et al. When FCR was compared to FC. Looking at these curves are shown every now and then, especially with people who really are convinced that chemoimmunotherapy should really be an option for patients with CLL. They're showing that the mutated group having a plateau after 10 years of follow-up, but the others showing lower progression-free survival. So, with the more recent trials that we have seen, this is the original RESONATE-2, based on which ibrutinib, BTK inhibitor, was approved for the treatment of CLL. As you can see here, there is no difference in this trial, which was compared to chlorambucil. Ibrutinib really overcome the mutational status of these patients, whether mutated or unmutated. You see these top curves are more or less overlapping, and this is after a 7-year follow-up of RESONATE-2. This is the ELEVATE-TN, again showing, and you've seen that, we've seen these curves, PFS, but we've seen them with the 17P, now with the immunoglobulin heavy chain variable region, whether mutated or unmutated. Now for the unmutated, I mean, whether the addition of obinutuzumab or not, were way better than obinutuzumab chlorambucil. And these are, to the right-hand side, the curves that show each subgroup, whether mutated or not. It's the top orange curves are for the acalabrutinib, or with obinutuzumab or not, and mutated or not, showing no major difference between the two groups. But again, if we come to venetoclax from CLL14, we've seen the curves of the P53 mutated. Now we come to the immunoglobulin heavy chain mutation. Again, the use of BCL2 inhibitor really, it does improve the outcome of these patients, whether mutated or unmutated. But there is a significant difference between these two groups, whether mutated or unmutated. As you can see the difference, as you can see the difference in the top two blue lines here, which represent the venetoclax or venetoclax mutated or unmutated respectively. So defining high-risk CLL translates into a careful consideration of predictors of response to alternate treatments. This is going to be my last slide. So if you use chemoimmunotherapy, you always need to make sure you don't use it, because 17p deletion, TP53 mutation are not really very much responsive, and it matters whether in general practice or clinical trials. Also, the outcome of patients, whether mutated or not, it does matter. Now, when you use novel agents, it depends what you're using. If you're using a BCL2 inhibitor, then probably the prognostic value of TP53 mutation and immunoglobulin heavy chain variable region mutation holds true. But if you use a BTK inhibitor, it doesn't really make a big difference, as patients with either TP53 mutation or immunoglobulin heavy chain mutation status did more or less similar to patients who did not have these mutations. With this, I thank you very much for your attention, and I'm happy to take questions if there is any.
Dr. Nijadi, thank you very much for a very nice presentation, trying to make it easy what exactly is a high-risk CLL based on genetics and the immunoglobulin heavy chain rearrangement. Our next topic will be continuous versus time-limited therapy in patients with high-risk CLL. And our speaker is Professor Wojciech, who's talking to us from Poland, from the Mary Solarski-Curie Cancer Center. Please welcome Professor Wojciech.
Good afternoon, everyone. Now, I want to welcome you from Krakow, where we have a sunny day today. And in the next 20 minutes or so, I would like to talk with you about continuous versus time-limited therapy in high-risk CLL patients. Regarding the consequences of today's world, I'll try to keep my presentation short. Now, the CLL is the cell which is not dividing. Therefore, it is not the ideal target for chemoimmunotherapy. We have BTK inhibitors, BCL2 inhibitors, perhaps IP3K inhibitors, and modern antibodies. But the key question is whether at all chemoimmunotherapy should be regarded an option. Then the other question is whether the molecular targeted therapies should be continuous or time limited. And if so, time limited, whether there should be MRD guided, whether there should be BCL2 inhibitor or BTK plus BCL2 inhibitor. Most of the problems are in the first line, chronic lymphocytic leukemia, because here the differences are not that distinct. The 2020 ESMO recommendations for the first-line therapy are straightforward. In patients with TP53 mutation or 17p deletion, it's BTK inhibitor or venetoclax-based regimens. In patients without 17p mutation, but with an unmutated EGHV status, we also recommend the molecular targeted therapy. However, here, venetoclax and obinutuzumab may be placed on the first place in unfit patients. Well, in the best prognostic subgroup, still we should carry on unless we have a very good risk cases, because the greater the risk, the more important the role of BTK inhibitors. Now, in fact, the only patients we are allowed to treat with chemoimmunotherapy are those fit patients with a mutated EGHV status without deletions, without 17p deletions. This means that the best of the best. But to offer chemoimmunotherapy, we are obliged to do all the lab tests to exclude cytogenetics abnormalities and to determine the EGHV mutation status. If we don't do this, it's always safer to go for the targeted therapy. As you see here, in the first line, the chemoimmunotherapy does pretty badly in case of difficult cases. In worse patients with 17p deletion or p53 mutation, the Bruton tyrosine kinase inhibitors do nicely. And the second generation Bruton kinase inhibitors like acalabrutinib do even better. Now, I will not guide you through the details, but just want to let you know that acalabrutinib development in chronic lymphocytic leukemia was very profound, starting from the first phase protocols, then demonstrating the benefit in relapsing refractory cases, and eventually treatment naive, all finished up in meaningful third phase randomized studies. So going for untreated patients, the first study was elevated in treatment-naive patients, where we took all the patients, all the elderly patients, and randomized against acalabrutinib-containing arms and obinutuzumab with chlorambucil, which was a standard at that time. And you can see the clear difference, which was already demonstrated by my colleague before. At 3 years, we had over 90% of progression-free survival in patients treated with acalabrutinib. If we are talking about high-risk cases, like 17p deletions, we had at 3 years progression-free survival of about 80% in EGHV unmutated patients, about 90%. And that's all for acalabrutinib. The obinutuzumab arms were much, much worse. The long-term efficacy of acalabrutinib-based regimens, kind of summary, will be one of the abstracts presented at EHA conference next month, a kind of meta-analysis. The frontline therapy with FCR was also challenged by the time-limited BTK inhibitor, namely ibrutinib with rituximab, given until the MRD could have been demonstrated. And again, here you have FCR, so we are talking about the good patients. And again, you can see the difference in overall population. And in high-risk cases. And again, in high-risk cases, if we have the Bruton tyrosine kinase inhibitor, we can think about 90% of progression-free survivals in 17p deleted cases or EGAV unmutated cases. We also had the CLL14 study, the first time-limited study, where venetoclax with obinutuzumab was faced chlorambucil and obinutuzumab. So it was the elderly population with higher CS score. And in here, there was a time limited, namely, we carried on this therapy for 12 months. This is, it was quite reasonable in our overall population. As usual, targeted therapy was better than chlorambucil and obinutuzumab. But once we look at sub-analysis of the patients with high risk, like 17p deletion or mutated status, then the results were worse than in ibrutinib. They were no longer 90%. They were around 70% progression-free survival at 3 years. Now, the rationale of combining Bruton tyrosine kinase inhibitors with BCL2 inhibitors lie in a synergism. The ibrutinib mobilizes CLL cells out of the lymph nodes and other protective lymphoid niches, inhibited proliferations, and sensitizes it to the BCL2 inhibition. Once we look at the very worst cases, and this is a single institution study at MD Anderson presented last ASH, they found over 100 patients either with a 17p deletions or with TP53 mutations. And as you see, there was no difference whatsoever whether they treated those patients with or without deletions as calculated by the threshold code. But there was a marked difference comparing the venetoclax plus BTK inhibitor versus BTK inhibitor only. So the synergism was clinically meaningful and was statistically significant for progression-free survival, marginally. It was just a trend for overall survival, and these were the first-line patients. Professor Geer reported last ASH a wonderful study where he just had ibrutinib kind of pre-treatment followed by ibrutinib plus venetoclax. The venetoclax was just started from the 4th cycle just to prevent tumor lysis syndrome, and the therapy was continued for 12 cycles. And then patients were randomized according to MRD status. If MRD was undetectable, they were randomized versus ibrutinib and placebo. Once we could not confirm the undetectable MRD, they were carried on with ibrutinib or ibrutinib plus venetoclax. And you can see that there was a high-risk population. It was the first-line patients, but there were 20% of patients with 17p deletions, 17% with 11q, 19% with complex cardiotype, 60% with unmutated EGHV. So the worst of the worst. And the results of this therapy, although time-limited, were absolutely fantastic for both groups. So it proved two things. First, that if we have MRD negative disease, perhaps we can observe it because the placebo patients did exactly the same as ibrutinib patients. And second, that if you have the unconfirmed MID, ibrutinib maintenance was good enough and we shouldn't go for ibrutinib plus venetoclax. Now, what happens in relapsing refractory cases? Well, it's absolutely certain that the worst of the worst, so relapsing refractory with 17p deletion or TP53 mutation, are to go for BTK regimen or venetoclax plus a monoclonal antibody in this order. Those patients with short remission as well. Only the patients with a long remission may be recommended to go for the targeted therapy, but repeating the frontline therapy is allowed. However, let me go through the couple of the studies. The ASCEND protocol was already mentioned today. It was the relapsing refractory CLL cases who were randomized towards acalabrutinib versus physician's choice. But in fact, physician's choice were Idela plus rituximab, as it happened in over 3/4 of the patients. We had a high-risk group. It was just a relapsing refractory setting, so 18% of 17p deletion, 32% with complex karyotype, 76% of unmutated EGHV. A smashing difference for an acalabrutinib arm was much better than investigator's choice. Now, once we looked at 17p deleted patients, the result was clear as well. And it gave about 65% of patients progression-free if we have them on the long-time lasting ibrutinib. Similar thing for unmutated EGHV status. We looked at the adverse events of special interest, and it was a second-generation BTK inhibitor. They were not frequent. However, we should note that idelalisib had the largest proportion of the patients which were discontinued on therapy. The next study I want to show you was a study in high-risk population only, so it was just 17p or 11q deleted patients, and there was head-to-head comparison of acalabrutinib versus ibrutinib. There was a non-inferiority study. We could not demonstrate any differences whatsoever in whichever subgroup we analyzed. In about 36 months, we had about 60% of patients with a progression-free survival. However, if we looked at the adverse events, we could clearly demonstrate that a second-generation inhibitor had less treatment-related adverse events, including those leading to treatment discontinuation and those in grade 3. Specifically, the cardiac events and hypertension were much lower than in ibrutinib arm. One thing I want to mention about cardiac toxicity, if we look at the population we treat, the elderly population, this is the curve which was done in a patients not treated with a BTK inhibitor. That's occurrence of atrial fibrillation and flutter, which happens in those patients. So you can see that this curve was superimposable with the one we observe in acalabrutinib, while with ibrutinib, it was twice as much. So it happened with the hypertension, bleeding events, diarrhea, arthralgia. Eventually, we had the last second-generation BTK inhibitor, zanubrutinib. And in this study, we took all the patients, and again, it was head-to-head with ibrutinib comparison, with statistically significant progression-free survival differences at first interim analysis. However, we could not draw any conclusions about the frequency about progression-free survival at 36 months yet. At 18 months, in 17 p-deleted patients, it was over 90%. Again, second-generation BTK inhibitor, so a great toxicity. Nothing is happening here. Now, let me give you the Bruin study. Bruin study is the study on pirtobrutinib, which is the third-generation BTK inhibitor, and we had 296 CLL patients. Well, in this study, we had a lot of patients which were discontinued due to progression or toxicity of the previous BTK, from the previous BTK. And again, we had a marvelous 70% progression-free survival in patients failing previous both BTK and BCL2 inhibitors. And the benefit was regardless of the risk group. And the patients with mutation in C481, which is one of the main causes of acquired BTK resistance to the first and second generation BTK inhibitors, did equally the same as those without. Murano protocol, time limited, venetoclax plus rituximab versus bendamustine rituximab. I call it a victory under Murano because it's absolutely great and significant difference. However, if we go for progression overall survival, the difference is meaningful as well. But if we go for high-risk patients, we cannot demonstrate a success. At 36 months, it's again much lower than in a continuous therapy. Presumably, it's holds because the therapy here takes 2 years and not 1 year, like an obinutuzumab venetoclax in the first therapy line. And that's just demonstrating you what was a doubling time, and indeed there was a difference. And with those with abnormal 17p, so with 17p deletion, the doubling time was 44 months, and with those with normal, twice as long, 85 months. Therefore, we could just say that this therapy is not that effective for high-risk CLL cases. Last study I want to demonstrate is time-limited venetoclax and ibrutinib in relapsing refractory. So venetoclax was given with ibrutinib, and then the patients with MRD negativity were randomized towards ibrutinib maintenance or observation until MRD positive and retreatment. And that was the Hoven study shown last ASH. As you can see, for the worst of the worst cases, the efficacy was great. That was again the gain of the synergism between BTK and BCL2 inhibitor. We could see over 80% of patients either with undetectable minimum residual disease or with low positive minimum residual disease, which still meant complete clinical regression. And so it happened with those with unmutated EGB status or complex karyotype. And the primary endpoint which was progression-free survival. At 12 months, it was 98%. And indeed, we can see that such an option allows us to, for both options. So MRD-guided ibrutinib venetoclax, it was feasible with progression-free survival of 98% in 1 year. MRD levels remained stable for MRD-positive patients 1 year after switching to ibrutinib maintenance. So in total, MRD-guided stop-start of ibrutinib venetoclax could be recommended similarly to CLL. There are other studies with venetoclax BTK inhibitor combination ongoing. Therefore, take-home messages are that targeted therapy is an undebatable standard of care in relapsing refractory chronic lymphocytic leukemia and is moving to the first line as well. It's an approved standard in the patients with 17p deletion or p53 mutation. It's an approved standard in patients with unmutated EGHV status. It is highly recommended for all untreated CLL patients. Now, knowing that, solving the first question now, what should we go for? The BTK inhibitors or BCL2 inhibitors, possibly with a time-limited therapy. Discussing this, we have to understand that we should not compare BCL2 or venetoclax results to ibrutinib results. If at all, we should compare BCL2 inhibitors results to modern BTK inhibitors like acalabrutinib or zanubrutinib. Now, my thinking is that although we can say that both are alternative solution, neither can be regarded superior. However, long-lasting therapy seems to be more efficient in high-risk patients, unless we go for the time-limited protocols, which are based on MRD and actually include both BTK and BCL2. So again, to summarize it, if we have a high-risk patient, a long-lasting therapy based on BTK inhibitors is always better, and the only alternative being BTK and BCL2 inhibitors together, and then could be stopped if MRD guided. For the patients with low risk, there is no an absolute benefit between BCL2 and BTK inhibition. We can use both things, although in the time of pandemia, the time-limited therapy has its charm. And I want to stop here and perhaps take the question at the end of the meeting. Thank you.
Thank you, Professor Wojciech, for summarizing the treatment options in high-risk patients. I think you brought out two very important points, and you talk about the role of MRD, which may be relatively easy and where you practice, but it's difficult in different parts of the world. And second thing, coming of age of a combination of BCL2 and BTK inhibitor together, which may be a very good option for patients with high-risk disease. Let's move forward and let's ask Dr. Iman Al-Hazmi, who's a consultant of adult hematology in the Department of King Fahd Armed Forces Hospital in Saudi Arabia. And she will be talking to us about translating all the data from clinical trials and how does she use it in practice. Please welcome Dr. Iman Al-Hazmi.
Thank you, Dr. Arif, for the nice introduction, and thank you for our attendees to be here this evening. I would like to start my presentation, as it's a clinical translation of trials, by sharing with you one of our cases. She's a 76-year-old female who's non-diabetic and hypertensive and referred to us in hematology with the leukocytosis back by the end of 2020. She had no big symptoms. She was totally fine other than incidental finding of leukocytosis. Her performance status was 2, with the limited mobility and activity, still she was able to take care of herself. So initially on a presentation, she had a white blood cells of 49, mainly of course lymphocyte with anemia. Her hemoglobin prior to presentation, like the last CBC was done in 2018, her hemoglobin was normal. And her platelet was okay at this time. That was positive then because of a little bit high MCV and LDH. Her estimated GFR was around 44. Even through the couple of years she's been following with us, her GFR was around 44 and 50 ranging. So peripheral blood flow cytometry done, and it showed lymphocytosis, mainly typical of CLL. They commented in the peripheral blood that she had pro-lymphocytes in peripheral blood. And there was no specification of the percent of pro-lymphocytes. FISH was done, and it was positive for trisomy 12, negative for 11q and 17b deletion. Her beta-2 microglobulin was 5.8. Immunoglobulin heavy chain status was not done at that time because of logistic issue that happened during that period of time when she presented. So that was in October, by the end of the 2020, October 2020. So this is when she initially presented. Then in December, more than a year, she started to have these symptoms with a night sweat, fever. CT scan was done as they gave a history of enlarging lymphadenopathy. With that, CT was done and showed multiple enlarged lymph node, different areas above the diaphragm, below the diaphragm, cervical, supraclavicular, axillary, but the largest were axillary up to 4.8 cm and portocaval, retroperitoneal, external iliac 5 cm. She had enlargement of the liver and the spleen, both. That was done in CT. The patient was living outside Jeddah, so she wasn't coming regularly. With the virtual clinic option, they found it an ease to just have a virtual clinic. Sometimes we don't have even a lab for them. But by February 2022, 2 months later, after she started to have these symptoms, she presented to the emergency department with history of sore throat, fever. Because of course of COVID-19, the patient was admitted as high risk COVID. Swab done twice before it cleared from the ID or infectious disease team. Her symptoms improved, but the lymph node, the palpable lymph node were bigger than what it used to be. It was tender. After that, it was tender. And there was a ground glass opacity, was suspicious of either infection or inflammation. Bronchoscopy at that time done, and that's one of the reasons that we kept her in isolation as a highly suspicious COVID-19. Even the CT might suggest to be more specific and sure what is the diagnosis with the lung. We did a bronchoscopy and the bowel was negative for any inflammation. So excisional lymph node biopsy then, as they confirm and family confirmed the enlargement of the lymph node worsening than before, to make sure prior starting any treatment that the patient did not have a transformation. It's just a progression of her disease. And they reported it as CLL, chronic lymphocytic leukemia, with the presence of expanded proliferation pro-lymphocytes. As we mentioned, if you remember, since she presented peripheral blood film, there was excessive pro-lymphocyte, and that might correlate to a worse prognosis. So here we are, almost 2 years after, more than like 14 months since the presentation. So what we started after we confirmed the that the patient has no transformation, only chronic lymphocytic by histopathology, we started the patient on acalabrutinib March 2022. So here is her CBC changes and LDH changes when we initially was at the stage of watch and wait. Her white blood cells were maintaining, hemoglobin maintaining, and with time, over a period of a year specifically, her white blood cells shooted up and her LDH also. And here you could see it after we started treatment. Initially, we used to follow her up every 1 or 2 weeks. As I mentioned earlier, the patient is living outside Jeddah, but we convinced her, we assured her that we need to see her more closely in the first 3 months of therapy. And we can see dramatic changes in her CBC, her hemoglobin maintained. I believe before we start treatment, she required, her hemoglobin went down to 8, but now LDH is better, white lymphocyte is much better, and plus white blood cells. So this is the course of our patient, and as our patient is treatment naive CLL, we'll discuss the trials that looked into such patient treatment naive. The first study was the Acala with obinutuzumab or as a monotherapy, of course, in the comparison with chloramphenicol and obinutuzumab. And this is for 4 years follow-up. I believe we are familiar with the design of the study. They divided the patient into 3 groups to see the outcome of the 3 treatments. Of course, they included the old age group and if they have high risk. Performance status was based on performance status and 17 B deletion or not. All of this were looked at. The primary endpoint was looking into the progression BFS, as most of the chronic cases, that's what we look at for initially. And overall response rate and overall survival. They looked into undetectable MRD. All of those are secondary point plus the safety. Patient population in each arm almost comparable, and regarding the age group and the gender with other changes in the disease itself characteristic, the stage of the disease, all through all 3 arms, they were comparable. And we could see that 17B deletion and mutated TP53 were around, both were like around 25%, like 4% of the patient, with other poor prognostic cytogenetic changes. They were a big proportion in this study. So this is what we commonly see as the primary endpoint of the trial, looking into the investigator-assessed BFS, which is the primary endpoint, and we can see both arms that include acalabrutinib. The response was much better than patients who did not receive acala. They received chloramphenicol with obinutuzumab, with a huge difference between 87-78, and on the other side without acala, 25% only. Additionally, they looked into the median progression. The median BFS was not reached in both arms with acalabrutinib, and it was only 27 months with obinutuzumab and chloramphenicol. I need to move forward. So, and here when they looked into whether there is a difference response, In BFS, the result would be different based on the risk of the presence or absence of deletion 17p. And we could see that in acalabrutinib arm, they maintained a good response and a prolonged BFS in comparison to the arm of obinutuzumab and chlorambucil, again with a big difference from 76-75% to an 18%, and this is around 49-month study. Median BFS was not reached in acalabrutinib arms, whether as a monotherapy or combined with obinutuzumab, and was much less even when we look into overall BFS. In the previous slide was 20+ months, and here is only 17.5. Looking into the immunoglobulin heavy chain status, again, they maintained a very good response in BFS in comparison, our result in comparison with as an acalabrutinib monotherapy or combined with obinutuzumab with an 70+ to 80+ in acala arms, and this goes into 4% for patients who received obinutuzumab and chlorambucil. So the response is maintained with a longer BFS in patients who's receiving acalabrutinib, whether as an immune therapy, as a monotherapy, or as combined with obinutuzumab. And this is proven even with hazard ratios in comparison for the patient. And still they maintained a very long BFS when they receive acalabrutinib. As we mentioned, they looked into MRD, undetectable MRD, and the response, whether it's, they looked into overall response, they looked into the different response, whether complete or partial response. And you could see here that the response as a whole, overall response rate was 96 in combination of acalabrutinib with obinutuzumab, with a similar results when as an acala for monotherapy compared to only 82% in patients who receive obinutuzumab and chlorambucil. The majority of the change you could see, and most of the change you would see in the complete response rate is higher in patients with acalabrutinib combined with obinutuzumab, almost 31% compared to 11.2%. But at the same time, the overall response is comparable, and the partial response on acalabrutinib as a monotherapy was 81%. And of course, the result was comparing both arms, like the combination of acalabrutinib with obinutuzumab to obinutuzumab with chlorambucil, and at the same time, comparison was done between monotherapy acalabrutinib in comparison to combination of chlorambucil and obinutuzumab. Even though the response rate, the complete response rate was really high in all arms, especially mainly in the combination of obinutuzumab with acalabrutinib or acalabrutinib as a single agent or monotherapy. When they looked into the MRD status, the highest was in patients who received acalabrutinib in combination with obinutuzumab. Almost 1/4 of the patient, just above 1/3 of the patient, 38%, in comparison to only 9% of patients who received obinutuzumab in the combination with chlorambucil. Undetectable MRD was highest in the combination. So the main difference was the arms that had a combination of obinutuzumab with acalabrutinib or with chlorambucil. Overall survival, they were comparable, 93 for patients who received obinutuzumab with acalabrutinib, in comparison with an 88% with the other combination of obinutuzumab or acala monotherapy. Still, even though the overall survival was maintained in all three arms, almost 40% of the patient switched from obinutuzumab chlorambucil to acalabrutinib arm. And this is the main side effect that we can see in different arms. Of course, with the beta protein kinase inhibitor, the main concern, and we always start thinking, what is the risk of atrial fibrillation? What is the possibility that what we start to think of as soon as BTK were available for us to utilize for patients. The other study will be the first study that compared head-to-head acalabrutinib versus ibrutinib in previously treated CLL patients, untreated. That was a typo error. And this is the main inclusion criteria for patients within the study. They were included in the study. They looked in and they stratified them again according to the risk status, especially for deletion B, performance status, and number of previous therapy. It's a previously treated patients. The main exclusion was for patients with significant cardiac disease and therapy on anticoagulants, including warfarin or other equivalent, and a prior treatment of ibrutinib BCR inhibitors like and PCL2 and other BCR inhibitors or PCL2 inhibitor venetoclax. So patient received acalabrutinib or ibrutinib both till progression of the disease. Or unacceptable toxicity, with the primary endpoint is non-inferiority based on investigator review committee looking into PFS. And they looked into secondary point as safety, where they looked into atrial fibrillation, infection, and transformation with overall survival. The characteristic of the patient almost similar. Most of the patient even regarding a mutation of the groups around 10% mutation status or unmutated patients, immunoglobulin heavy chain. So the primary endpoint of non-inferiority and PFS, they both were, patients were followed for almost 41 months. And you can see it's very close PFS for both arms, ibrutinib or acalabrutinib. They looked into the incidence of atrial fibrillation, and they looked into and with a different percent for it, and you could see atrial flutter fibrillation occurred like around 10% in patients with acalabrutinib and 16% in patients with ibrutinib. But none of the patients were on that study who developed atrial flutter fibrillation discontinued treatment compared to 16% of patients on ibrutinib. So they looked into patients then who had developed atrial flutter. They were not known to have atrial fibrillation, atrial flutter. It was
sorry to interrupt. We're getting short of time. Can you please?
I think we're almost close. And this is the most common side effect in comparison. They looked into any grade of side effect or grade 3. And the highlighted in red is the more significantly seen in comparison in one arm for the other. The last will be the event that we usually think of and look for when we start patient BTKi, including atrial fibrillation, hypertension, infection, and it shows again in red the major difference between both arms. whether in any grade or a grade 3. And this is seen in diagram for the difference in atrial fibrillation and hypertension for acalabrutinib, and acalabrutinib is lower incidence in comparison to ibrutinib. And this is for the bleeding event, diarrhea, and arthralgia. And still we could see that acalabrutinib in the blue line, lower incidence of those side effects, especially like the bleeding event that we commonly concern with anticoagulation and AF on patient. And by this, I conclude my presentation, and thank you.
Thank you, Dr. Iman. We'll leave the questions and answers to the panel discussion. Now I'd like to invite Dr. Amarlal, who's my colleague at Tamam Hospital and consultant hematology oncology. After graduating from Dow Medical College in Pakistan, he completed his FCPS, and he's also did his postgraduate training from UK. He'll be talking about CLL management in the clinic. Dr. Lal.
Good evening, ladies and gentlemen, and thank you, Dr. Arif, for a nice introduction. And I'll have to go too fast because already too much time wasted. So my talk is basically to present the real world cases of high risk of CLL. So in next, maybe I will finish within 10 minutes. I will go through 5 agenda eye-openers, challenges and solution 2022, and how CLL journey of the patients, real world experience, and what is the advantage of continuous therapy. So which guideline we use all over the people? They are using 4 these guideline. In our practice, we use NCCN guideline, and sometimes we use expert online. So NCCN guidelines say frontline, it's all the therapies are available, but the challenge is which is the best for the patient. Other challenges are, CLL is a relapsing disease, and third challenge is for poor outcome for the high risk cytogenetics, and especially for frail patient. However, there is solution by presenting this, that CLL is the 2 disease, one is mutated and other is unmutated if you have availability of the molecular test. And other thing is more divisible if you go through by the cytogenetics, everybody know the worst is 11, 17, the rest is fine. So there is pros and cons of everything. Like ibrutinib has the longest data, but the problem is indefinite treatment and off targets problems. But acalabrutinib have resolved those off target. And again, fixed duration has some problem with the high risk cytogenetics, which was mentioned before. So as I always say, any chronic disease is marathon. So you have to treat the patient smartly. You have to see the efficacy and tolerability, at least, as already mentioned by each speaker, that tolerability is proven good with the second generation in Elevate Aura and Alpine trial. And more thing is coming in the future. BH3 profiling may allow the individualize the patient, and I will not go this way. So the solution is there. Fixed duration is for the young patient or low molecular risk, but continuation therapy is good for especially high risk and the older patient. And so how I go for a journey by CLL, in my case, I will go for A to G. A means accurate diagnosis before beginning the treatment, and C, check cytogenetics when there is indication, then drug for efficacy and feasibility, and then how I treat. So this is 5 years back. This is a 75-year-old male who has comorbidity of the prostate cancer, hypertension, ischemic heart disease. Initial presentation with the high cell count, WBC 14,000. He has similar count 1 year ago before as well when he was presented. He came to our hospital with the cervical lymph node biopsy that was proven as a SLL. So now the initial presentation is you can say stage 1 by Rai classification, no anemia, no thrombocytopenia, no fatigue, so no indication, the observation. So he was observed 2 years. After 2 years, he developed actually B symptom and all the symptoms and lymphadenopathy and splenomegaly increase. He's physician himself. He started actually clarithromycin based himself for 3 months, but he didn't get benefit. Eventually, he came to me. So I went see for, check the cytogenetics and the molecular test. Cytogenetics, we send outside. This is a problem. It didn't come back the result. But molecular test, again, is maybe reliable or unreliable. Is some institution, they sent us the patient has the mutation. So the patient has comorbidity, as I mentioned, cardiovascular disease. So now we have option all the BTKI and fixed duration, as well as mentioned by a previous speaker. So how we use by expert on guideline, if the patient has the first mutated, we can use the BR, or if the patient has used actually clarithromycin by himself, so you can make it second line as a marinovirus trial, VR-based chemotherapy, or we can assume if it's not used as a acalabase chemotherapy. So all the three options are here. So in this patient, actually, I use marinovirus trial. This patient is now 77 years. So we have mutated and we have unavailable fish. So VR-based chemotherapy was given, and as everybody knows, 2 years protocol after finishing. So you can see these are the graphs of the WBC, lymphocytes, and LDH. Everything went down and symptoms improved, of course. But after 6 months, you can see the disease again progress with the symptoms also. Only just after 6 months, he developed again progressive fatigue, weight loss, early satiety, and again, it was confirmed on the flow that is CLL is there. And the thing is here, you can see the graph just after 6 months after fixed duration. Then, the things which we sent, important thing, fish and I would say fish and meat. The meat is the molecular test, which was done here. It revealed unmutated, and the fish is 11Q. So it's, of course, it's high risk by this way, and also a high risk the patient developed after 6 months, disease came back. This is indicating is a high risk patient. So now the option is again there. So what expert on guidelines say, based on this, again, because of ischemic heart disease, the best thing is if you can give acalabrutinib, if available, it's in 2021. But the patient started, BTK inhibitor now 1.5 years. He's on continuous therapy of the BTKI, and you can see, so this is the graph of the white cell and LDH, which went up, and also symptomatically, of course, which is very important, fatigue, and all the B symptoms gone, on all the splenomegaly and lymphadenopathy is gone. So this is, just scenario, just, what problems we face. We don't have, neither we have fish nor we have meat. Meat means no molecular. This is the problem. Fish means, cytogenetics. So anyway, we started this way, and this is the, now the patient has come high risk. So similarly, another case, just 2 minutes, 83-year female with multiple comorbidity. She was following to us in 2014. She was doing great. In 2016, she developed some symptoms. She went to Bangkok, and there was started actually marvelous-based chemotherapy. Again, no fish, no meat, no molecular tests. Marble test was given. So, but after a few months, its disease came back. Then again, Morono trial was given. But after 6 months, again, it came back. So now she's on continuous therapy. So, and again, this is a scenario in our patient where you don't find either fish or molecular test in this patient. So how this is the journey. This is the lymphadenopathy of the patient. And this is how about the journey of the patient who is on now continuous therapy from October 2021 till now 2022. Now she is doing great. So third case, again, very quick, high risk patient, 62-year male, diagnosed 2010 actually. It was diagnosed even MD Anderson, very high profile patient, 17P deletion they checked. Although we don't check if patient has no any symptom fatigue, but anyway, they checked his 17P deletion. He was well about 7 years. And again, 2017, he developed some symptom. And again, they recheck it. It is again TP53 gene and also 17P deletion. So they started continuous therapy on this patient. And this is, I will not go resonant trial efficacy, which was, outdated in 17P. And this Elevate trial, they have shown the good efficacy in 17P. Similarly, Ascend trial, they have shown the good efficacy in high profile patient. And tolerability, again, is good, if you use the second generation 2 versus first generation. So anyway, in short, this is my last patient where the BTK was given. This was the SMART decision because, as I mentioned, high risk patient, and it was not given fixed duration of the therapy. So over the 4 years, he is taking based on the continuous therapy of the BTK inhibitor. This is the profile of the patient. So last 10 to 15 minutes, what I wanted to describe here, I went through the eye-opener questions, some challenges, and my journey of the CLL. And I briefly presented 3 cases, all new cases. 2 cases were high risk, really high risk. And third case, as I mentioned, there was no fish, no meat, and no, treatment, and no predictive marker there. Now, my question is, how do you predict fixed versus continuous therapy? Now you have bird of ibrutinib, Acala, Xeno, first generation, second generation, or you wanted to give fixed duration therapy, or you wanted to give fixed duration therapy of venetoclax plus ibrutinib, or venetoclax plus Acala ibrutinib. So this is my closing question. Now I finish my talk here. Hopefully you get something. Thank you very much.
Thank you, Dr. Lal, sorry to speed you up, but for the sake of time, and you did it very well. So let's go to the panel discussion, and I would ask Dr. Iman and Dr. Iman if they can kindly join us. We have Dr. Wojciak with us. So let me start, Dr. Iman, you are muted. If you can unmute yourself.
Yes.
Let me start first. We have a number of questions from our audience, but let me start with Dr. Iman Al-Jazi first. It's good to see you again. But 2 questions for you. What is the availability of the new generation BTK inhibitor in KSA at this point in time? Is it readily available, or you have to struggle a little bit? And second thing about the, all of you have made it very clear that CLL is a very heterogeneous disease, and one CLL does not behave as another CLL. It's all based on their genetics of the disease itself. How readily is the diagnostic facilities available in different institutes in KSA?
Well, thank you, Dr. Arif. For the first question, we do have at our institution venetoclax and ibrutinib that are formulary and readily available. Of course, I mean, not all institutions probably, or all hospitals have the same drug formulary list that we have, but the big hospitals, I guess, at least have ibrutinib and venetoclax in addition to chemoimmunotherapy as we know them before. Acalabrutinib, we have it as non-formulary, but not yet within the form. And when I say formulary, that means it's available in the pharmacy, available in the shelf. I can just prescribe it and it will be given to the patient. Non-formulary means that I need to request it specifically for a patient, and it takes about a few weeks to be available for the patient. We have used acalabrutinib mainly in mantle cell lymphoma. We haven't used Acala in CLL yet, but venetoclax and ibrutinib are available. Now, the diagnostic tests, at least in King Abdulaziz Medical City, National Guard Hospital in Riyadh, we have the conventional cytogenetics, we have FISH, we have molecular testing. I mean, all are available, including the immunoglobulin heavy chain mutational status and P53 mutation.
One quick question before I go to Iman and Dr. Wojciak. Do you have readily available data about the incidence and prevalence of CLL in KSA? Is there a registry? Is there anything been published so far?
Unfortunately, we do not have, we have a registry, which is the cancer registry in Saudi Arabia, but that does not have a lot of details. It's only probably the number of cases, and it lumps all leukemia together, chronic leukemias, and then subdivides them into CLL, CML. But to be honest, we do not have a comprehensive registry in the country where I can say for sure how many cases of CLL are available in Saudi Arabia. But What was the rest of your question? Sorry.
That was it, I think. Let me go to Dr. Iman. Dr. Howard, thank you very much for, you're muted. Thank you very much for a very nice presentation and summarizing the data. So for your patient, why did you choose acalabrutinib as first line rather than other medications?
So to start with, it was the option of whether or not to start the patient in chemotherapy, like the classical, what we knew for years as the only option, FCR, but was, of course, was out, especially with the comorbidity and age group. And then comes to targeted therapy. And one of the things where, because of she's with the diabetes, hypertension, comorbidity, and less risk, although her ejection fraction, I believe, was normal and her ventricular function was okay in echocardiogram, but was the concern with the comorbidity and such age group, which she had a higher risk of atrial fibrillation, developing atrial fibrillation, and then we go with the dilemma. So that was one of the main point that deviated us towards acalabrutinib as the incidence of atrial fibrillation is less frequently seen. Patient started on acalabrutinib. That was the main point that make us switch to start the patient on acalabrutinib.
Thank you, Dr. Iman. So let's come to Dr. Wojciak. Dr. Wojciak, as you know, you have a lot more patients than any of us have seen because, as you know, as you move east, the incidence of the CLL keeps going down. So one of the questions to you is that in your clinical practice outside of a clinical trial, how do you choose which BTK inhibitor do you want to use in a particular patient?
Well, ibrutinib was the first in class. It was a breakthrough. Once we had nothing but ibrutinib, we chose ibrutinib. Now, the second generation BTK inhibitors are not yet refunded in our country, but we've done a lot of clinical studies, which meant that we've treated over 500 patients with second generation BTK inhibitors and another 250 with pirtobrutinib, which is a third generation BTK inhibitor. You're in a lucky country where both drugs are available and refunded. And I would say that there are a few differences between one and other second generation BTK inhibitors. Whether you use acalabrutinib or zanubrutinib, it's not really a difference. However, the toxicity is so considerably lower if you're compared with ibrutinib that I would go for them without any hesitation. The drugs are simply safer, better tolerated, and the cardiotoxicity and bleeding are among the two leading causes why I would rather omit ibrutinib wherever possible. But we have to take into the account that we are still having COVID pandemics, and that therapy with BTK inhibitors, which is a long therapy, is maybe not recommended for the patients who do not develop immunity, who are not vaccinated before, who are having a lot of infections. Therefore, in a low-risk cases, I would perhaps go for the time-limited BCL2 inhibitor-based option, but only in the low-risk cases. All the others, I would carry on with a second-generation BTK inhibitor or a combination of a second-generation BTK inhibitor and venetoclax, if that's available within this study, possibly MRT-guided.
But off study, let's say you had a patient on BTK ibrutinib who is failing. So off study, you would go with a BCL2 inhibitor plus a anti-CD20 antibody at this point in time?
Well, if I had a patient in, for example, Saudi Arabia on ibrutinib, I would just switch him to acalabrutinib, zanubrutinib.
But in your clinical practice,
other patients, I would not wait until he develops any kind of intolerance. Why should we? I would not like my patient to develop atrial fibrillation if I could spare it or prevent it by switching him to the other agent.
You brought up a very interesting point about the COVID infection, and ibrutinib, as you well know, that is being used as part treatment of GVHD. What is the what is the effect of the second generation BTK inhibitors as for? Do they have the same potent immunological effect as compared to ibrutinib, or they don't have as much as off-target effect?
Which effect? Neuro?
Off-target effect for well,
I mean, the off-target effect is simply less seen. If you look from the laboratory point of view, it is clear and evident. But for me, the most important were clinical observations in the randomized studies. So if you took the studies like the Alpine or Elevate or Sequoia, where we are comparing just head-to-head ibrutinib with the second generation BTK inhibitors, it was absolutely clear that not just cardiotoxicity was less common, but also the adverse events leading to treatment termination and to the drug switch. I understand that ibrutinib might look nice because it's just once a day drug, but the patients do tolerate twice a day drug pretty well. And I think that this is something which they should be recommended wherever possible. Simply, it's just like a story about beta blockers. Who remembers propranolol? We all use metoprolol or the others. And it's the same kind of story.
Thank you, Dr. Wajid. I have time for a few more questions. Let's go to Dr. Iman. So Dr. Iman, one of the panel audience sent a question is that, let's say they don't have access to fish. How would they base their treatment? Should they base it on, should they try BTK inhibitors? Should they try venetoclax with obinutuzumab? Should they do? What would you recommend?
Now, if fish is not available, I've mentioned in my talk that the use of BTK inhibitors has overcome the worst prognosis that is seen in patients with 17p deletion, p53 mutation, or unmutated immunoglobulin heavy chain variable region. So if they have a BTK inhibitor, they can just start BTK inhibitor without having these tests done, bearing in mind that they will have a drug that can overcome these abnormalities. I wouldn't advise any to start without fish, to start chemoimmunotherapy, for example. Now, if we come to BCL2 inhibitors, they still overcome these problems, but probably if given alone to a lesser extent, and there is some difference still between patients who are p53 mutated or 17p deleted as compared to those who do not, and also the immunoglobulin heavy chain variable region mutation status. There is still some difference in the outcome of those patients who are mutated and unmutated if you use venetoclax-based therapy without adding a BTK inhibitor.
If I may just say that BTK inhibitor is like fire and forget. You do not have to think a lot before, and you don't have to think a lot during therapy. If you want to treat the patient, yeah.
Please go ahead. Sorry to interrupt.
Well, that was on the kind of comparison I would like to give, because with venetoclax, with chemoimmunotherapy, you need to go for fish, you need to go for the mutational status, because otherwise you should not be allowed to give it. With venetoclax, you have to look for the kidney failure, you have to see the patients more frequently. So if you have a patient you don't want or you can't see frequently, just BTK inhibitor seems to be the best for him.
Okay. I think we have time for one last question, and I will point it for you, Dr. Wojciech. So in 2022 and beyond, what do you see if reimbursement was not an issue? Would you see still single agent BTK inhibitors like the next generation BTK inhibitors as therapy, or would you think that a combination of BTK inhibitor plus BCL2 inhibitor would be the best for patients with high-risk disease? Dr. Ojik, you are muted. Hello.
You want me to answer it?
Yes, please. This is our last question, I think, for the sake of time.
I don't quite understand your question, but if you're talking about the combination versus...
Right. So if reimbursement was not an issue in 2022 and beyond, would that be the best solution for patients with high-risk disease?
Well, in the first, we have the life after BTK inhibitor intolerance or failure. And we can either use the combos with venetoclax, so we can use the third generation BTK inhibitors, which are pretty much efficient. And the adverse events of pirtobrutinib and other third generation BTK non-covalent inhibitors are even less pronounced than the second generation BTK inhibitor. So there is a steady progress. But I don't know whether I answered the question because I couldn't quite understand it.
I'm sorry. So the question from the audience was that what is the future of combination therapy in CLL? I believe they're talking about combination of BTK inhibitors plus BCL2 inhibitor.
I would say that unless we find a curable option, this is still investigational. I would not start with this outside clinical studies because if we use it up front, there is a very few things which we will have left. We are learning how to use it. It has to be in a controlled way. I would rather say that the good results of those combinations may encourage us to use a monotherapy with Bruton tyrosine kinase inhibitors up front, and not to be afraid of the fact that we will not be able to treat our patients after the failure. But unless we have some confirmed solid data on either cure or a really long-lasting progression-free survival on the combos, I would not recommend them in everyday practice yet.
Thank you, Dr. Ojik. I think for the sake of time, we are really over the time limit. And I would like to thank all our panelists and speaker, Dr. Ojik, Dr. Iman Al-Hijazi, Dr. Iman, and Dr. Amarlal. It's getting late. We don't have any other questions from them, neither do I have any. Please accept my sincerest gratitude for participating in this. Thank you, AstraZeneca, for organizing this meeting, and please fill up the for the audience for the CME the review part. I'd like to thank everybody and have a good night.
Thank you.
Thank you.